Hey everyone, welcome back to another episode of Chasing Optimum. I have a fantastic guest today that I have searched high and low for. And Lara Briden, how are you?
Yeah, good. Thanks, Matt. Yeah, how are
Uh,
you?
Good, thank you. We're in different parts of the world. You're in New Zealand, I'm in Australia. Yep. And I have been searching for the right women's hormone specialist for a very long time. And a friend who's a nutritionist said, if you can get Lara, she's the best of the best. So thank you for giving me your time.
Yeah, you're very welcome. I'm looking forward to having a conversation.
Excellent. So I've looked at you on Instagram. I didn't know you before Dina put me in touch with you. But could you give us a little bit of a rundown on what you do and who you are? Just, yeah.
Yeah, easy. So I'm a naturopathic doctor. I'm Canadian, that's the accent, but I spent 15 years in Sydney, Australia. So I'm partly Australian and now I live in New Zealand. And um, yeah, I've worked for almost 30 years treating women as a naturopathic doctor. So treating women with nutrition, diet changes, lifestyle, herbal medicine. And out of that work, I came three books. So my first one, Period Repair Manual, was all about periods, menstruation. Then my second one, Hormone Repair Manual, was all about perimenopause for women over 40. And
Yes.
I have my latest book released last year is on metabolic health for
Yes.
women of any age. So that was kind of my deeper dive into insulin resistance and metabolic health.
Awesome. Let's touch on all of them. So are you a consultant now? Like if someone is in Australia and they think, oh, I need to talk to Lara, do you still take people on? Do you not? How did
I still see patients, mostly face to face in Christchurch, where I am. I have a lot of Sydney patients though, because I was there for so long. So I actually fly to Sydney a couple times a year and rent a consulting room and see people there. I occasionally let a new patient slip through because it's just nice to sit down with a new person and,
Yeah.
problem solve and troubleshoot. Yeah.
Absolutely. Can you tell me about hormones? Obviously, I know a bit about male hormones. I
Mhm.
take testosterone myself and things like this. I'm 52. So with women, and you touched on it there, I've got a lot of questions from my audience, by the way, that I'm going to get straight into after we talk
Yeah.
about. But can we set the tone for hormones, how important they are? Like there's things like estrogen, there's things like testosterone, there's things like all this stuff. So how does it all work?
Yeah. Well, I want to start with this. So my background before I became a naturopathic doctor, I was an evolutionary biologist. So I do tend once a biologist, always a biologist. I think you can't unsee that sort of thing. So I see everything through that lens, and just the framing I like to do. It's just a little playfulness. Is that female physiology is the standard normal version of physiology, and male physiology is the kind of quirky variant. Um, so men are quirky in that you make your testosterone every day, which is like, oh, what an unusual way to do it. Women are cyclic. So women make their two main hormones, estradiol, our main estrogen, and progesterone, which you didn't even mention, which is the companion hormone to estrogen, is actually very important. And those two hormones we make during our reproductive years, we make them on a monthly basis. That is, if we're not on hormonal birth control, because the other weird thing that's been going on for women for about 60 or 70 years is there's been this, as you probably know, routine procedure of switching off women's hormones with hormonal birth control. And that's actually one of my, throughout all my decades of work, that's been one of my key messages, is that that's maybe not a great thing to do. Women benefit from their ovarian hormones just as men benefit from their testicular hormones. Think about this, Matt. It'd be crazy. Like, can you imagine saying to young men, look, you don't need your testicular function or testosterone until you're ready to make a baby. So we're just going to shut it all down. And then we're going to replace your testosterone with this medication that's a little bit like testosterone, but also kind of more like estrogen. And, that will obviously affect your metabolic health and mood and everything, but not to worry because that's what we do. That's what it's been
Mm,
like for women
never
for
thought about
about
that.
three generations, 4 generations probably, because the medications in hormonal birth control are not the same molecules. They're not the same hormones that we normally
Do
make.
they do damage, Lara? Like what's the repercussion
Well,
then?
That's the million-dollar question right now. Everyone's scrambling to figure out because they're so widespread. I mean, hundreds of millions of women take these medications. And so fortunately, and we do know, I mean, we have some big zoomed out, you know, taking a broad look safety data. We know, for example, there's a small increase in breast cancer risk from any type of hormonal birth control, including the more modern hormonal IUDs. That risk comes from the progestin, which is very different from the body's own progesterone, which progesterone probably reduces the risk of breast cancer. So that's one example. And they're always looking for things like blood clots and cancer, of course, because those are the big things to be concerned about. But then more, you know, if you zoom in, if you kind of to women's lives, we do know that hormonal birth control affects mood in a negative way, potentially. Some women feel better on it, which is fine. But like on a population basis, all types of hormonal birth control increase the risk of anxiety and depression. And all types, especially the combined kind of estrogen types, prevent women from obtaining peak bone density, for example, in their 20s. So there's, you know, other things going on that shockingly haven't been studied as much as you think they would have been, or they're being studied now. I mean, we know hormonal birth control changes the shape of women's brains. So that's kind of new information. And the scientists who
Yeah.
are looking at that are just like, wait, what? Why did we never look at this before? You know, this seems quite important to know.
So you're saying them not to go on it at all?
Um, well, of course, no, I don't say that. I mean, the way I frame it is, I think it's just about informed consent, right? So hormonal birth control can be very effective. Obviously, it's a very effective method of avoiding pregnancy. It's not the only method. So I have a chapter in my first book about all the other ways to avoid pregnancy. And then it can, obviously, those medications can suppress and relieve symptoms and pain.
Mm.
And, you know, so I mean, I would never, some of my patients still take certain methods, especially the hormonal IUD, which I feel is a little better as well, put it this way, it's a little more nuanced than some of the other types. So no, I would never make a blanket statement that no one should ever take it, but it's just bringing it into the conversation. If we're going to talk, because your first question was, how does the female body work? It's like, well, we make hormones with a menstrual cycle. Ovulation, regular ovulation is how we make hormones. So it's hard not to talk about that without then talking about, well, what does that mean if you switch off ovulation or, you know, switch off women's source of hormones, essentially.
And that's in your book, is it? Like all of
Yeah.
that? Yeah. Okay.
Yeah.
Well, we'll put links up and so people can get
Yeah.
and things like that as well. So, can I ask you about endometriosis?
Yes.
Yes.
Well, it's also a big topic. So as you know, it affects at least 1 in 10 women. There's also, you know, a lot going on with it. I've got some new content coming out about endometriosis. Actually, I've got a new podcast episode and I'm doing a presentation in Melbourne next week for clinicians. So I don't know when this podcast will come out, but I'm going
Today.
to be over in Australia talking to, yeah, doctors and naturopaths about the condition. So any of your listeners, you know, if they have endometriosis, they already know it's this inflammatory disease that's associated with deposits of kind of endometrial or uterine lining like tissue kind of throughout the pelvis. It can cause a lot of pain and also infertility. And but again, there's nuance in there because there's sometimes you can have the presence of the lesions that may not actually be the cause of the pain. They might just be incidental, or in some cases, depending on the type of lesion, they're not always um, disease promoting. And also not all types of endometriosis lesions are progressive. So there is this narrative out there that once you have endometriosis, you'll always have it. It's just going to keep getting worse and worse. That is not what the research shows at all. There are certainly the condition can resolve on its own. It can respond to all various types of natural treatment. There's a strong link between gut health and endometriosis, for example, and there's a lot of science into that now. So, as a segue from our previous conversation, yes, certain types of hormonal birth control can suppress or relieve the symptoms of endometriosis. And so that might be the situation where, for example, some of my endo patients do have a hormonal IUD for that reason. So that's, you know, valid, but not everyone with endo automatically needs birth control. I mean, there's lots of other options.
So how does a woman stay hormonally fit? Like how does a woman stay, through the journey of life? Is it diet? Is it is it like how does someone, if someone's watching this going, I don't feel right, and I mean hormones, from what I understand, is like everything,
Right.
gut health and
So,
hormones. Like
of course,
what
the
do they
other
do?
yeah, the other quirky thing about men is that you kind of have the same hormones throughout your whole life, whereas women we have lots of different modes, lots of different gears of hormones. So during our reproductive years, the way to stay hormonally healthy is to have a natural menstrual cycle and a regular ovulation, and then also general, good health around that to support the cycle. And like, for example, a very common scenario, especially in the fitness industry, is especially young women. It's more for young, not so much for women over 35, but younger women can easily lose their period to undereating or undereating carbohydrates specifically. And it's not that I'm against a low carb diet, actually, but there's quite a bit of nuance around that too. But women's brains are very sensitive to food intake, and it makes sense right from a biology perspective that if the brain perceives there's not enough food coming in, it will temporarily shut down ovarian function. It will shut down hormones, and it's because it's not a good time to make a baby. The brain doesn't know why there's not enough food coming in. I mean, it doesn't know that the woman's just trying to diet or lose. It's like there could be, who knows? I mean, there could be a war, there could be a famine, there could be like it's so it has to respond that way. So that's quite a common explanation. So, but back to your question of how do you stay hormonally healthy through a lifetime? So, in your younger years, try to make sure you're ovulating every month, and having a regular bleed is no guarantee that ovulations happened actually. So, I can explain that a little bit more. You can track temperatures. There's all these ways women can. It's called body literacy, knowing if and when you ovulate, and if you're therefore making the hormones and the levels that you should be. And then, of course, there's pregnancy, which is a great huge dose of hormones beneficially for women's brains in particular. We do know from the research that having good levels of estrogen and progesterone, either from regular natural cycles or from pregnancy through a woman's lifetime, is good for her brain and heart later in life. So it's building up what's called metabolic reserve. So it's and bone health, and let people kind of know this about bones, but the same applies to other tissues as well. So that's really good for women to have that. And
Yeah.
then the other modes, I mean, there'd be postpartum. Women go to a very low estrogen state postpartum, but that's kind of offset by um, oxytocin if they're breastfeeding, for example. So actually, my new book talks about some of the different phases and postpartum and breastfeeding and kind of hormonally what's going on then, especially metabolically. And then, drum roll, of course, we have perimenopause and menopause, which men do not have. I mean, I know there's like an andropause, and testosterone does decline in a linear fashion throughout a man's life, just as testosterone actually declines in a woman's. Both sexes are the testosterone is just on it's gradual way down. But for women, we have a very different situation as we first go through perimenopause, which is this time of actually higher than normal estrogen, but progesterone dropping away. And that combo can create very heavy periods. Classically, during women's 40s, there'd be like these flooding periods where they bleed through their clothes, which is some of your listeners will know what I'm talking about, and get very iron deficient. And that's obviously a problem. And that time of recalibration during perimenopause when hormone levels are changing, it can really affect the nervous system. It affects the metabolic system. Everything has to recalibrate. And then eventually women do reach menopause or postmenopause, which I will say is a normal phase, like from a evolutionary biology perspective, we evolved to do this. And in a healthy setting, and if the environment was healthier and our food environment and everything was going well, we know from data from other cultures around the world that kind of postmenopausal years, women generally thrive. So it'd be like in their late
Really?
50s, 60s, into their 70s. So this being just taking, for example, it's kind of the data from around the world, but any of the modern day forager people, like the Hadza in Tanzania, I'm actually going to Tanzania in a few months. Just fun fact. It's a little, I can't mention Tanzania now without kind of saying, actually, um, as a holiday. But anyway, the Hadza live a very traditional lifestyle. Like all humans, they go through into menopause, in their late 40s, early 50s, just a normal human thing to do. and they're happy about it. And they don't suffer any symptoms, and they don't particularly get any long-term effects from it. Women, of course, across all traditional cultures, women still outlive men. And then those women in those traditional cultures, those women in their 50s, 60s, and 70s gather more food for the group than anybody else. Like what the evolutionary biologists and archaeologists looking at this, they're like, I'm not sure how these societies would survive without their 60 something women holding it all together,
Really? So
bringing
it's
in the
like
food. Yeah,
like a second wind in life or something, is it?
absolutely. And the men in some of those cultures, I mean, to be fair, men are like gathered around telling stories and occasionally going out to hunt, but the women are like every day, like just bringing in the calories, bringing in the like gathering the food for the younger women who are busy having babies and all the children. And so it's older. I'm trying to dispel this myth. There's this kind of narrative out there right now, which is just flat out wrong, incorrect. This narrative that, we menopause is new because we live longer than we used to. That menopause is not new. The life expectancy of humans used to be obviously much lower, but that was a statistical thing. So that's because it's very sad, but like even 150, 200 years ago, one out of two children died before age 5, which is, thank goodness, that has, that's not how most humans live anymore because it was so sad.
Mm.
But you can see how that would affect the life expectancy calculations. And also, a lot of people used to die from just things like infections and, broken
Mm.
bones and stuff would be fatal in the old days. And so, or could be. So, of course, many more people now make it through to their 70s and 80s, which is than used to. But it doesn't change the fact that there were always lucky individuals who could get through, and the human organism probably for a few 100,000 years has been, living to 70 or 80. And actually, the scientists think that selection for older women, post-reproductive women, is what drove that longevity, actually. So menopause, far from being an accident of living too long, menopause evolved because it's so great to have older women around.
Oh, interesting.
Yeah.
That's an amazing way to look at it.
Yeah.
Before I ask you these questions, because I'm on limited time with you, because you've got
Sure.
another
Yes.
one after this,
Yeah, I know.
and I've got a lot of audience questions here, and I want to
I
make
know.
sure
Okay.
I answer
Let's
them. But
fire them.
when you said something about not eating, so there's two things I want to touch on quickly, but not eating. So Ozempic, would Ozempic play havoc with your hormones?
Well, any kind of if it leads to undereating in a young woman, yes, it would. I mean, the other side of that, to kind of give the full picture, is women can also lose their periods to insulin resistance or metabolic dysfunction. So that would be polycystic ovary syndrome or PCOS. So in that case, for someone who's deep into metabolic dysfunction through no fault of their own, I'll point out actually, because my new book really unpacks that about how the modern population's been pushed into obesity, metabolic dysfunction, not because of poor willpower or anything like that. But anyway, for women who have been in insulin resistance and lost their period to that, in their case, Ozempic could bring their period back, or weight loss or diet changes will bring a period back. So it's toggled, right? So you can
Mm.
lose your period to not eating enough, and you can also lose your period to being in the state of kind of excess or insulin resistance.
And if a girl goes to the gym and she sees these, like slightly chunkier, sort of bodybuildy-ish type of women, that do some of this stuff and they take Anavar and these testosterones, how does that play around with the woman's body?
Right. Oh, good question, Matt. I'm not an expert. It's not a good idea to introduce more testosterone to a woman's body in general. I mean,
Right.
apart from some clinical settings. So yes, in terms of using anabolic steroids I think women could basically too much testosterone will suppress periods as well. But that's kind of equivalent to the polycystic ovary state. So I mean, without being an expert on, it's a good question, but I haven't sort of looked that deeply into that kind of medication. Well, if we could call it medication, performance enhancing. One thing I want to say on the PCOS side, this is
Yeah.
quick because I know you have some other questions, but
Yeah.
just a cautionary tale that the condition PCOS cannot categorically not be diagnosed by ultrasound. And the reason I say that is because this appearance of polycystic ovaries on an ultrasound that many women have received, had that test done, that can occur in women who are undereating. So you could have someone with what's called hypothalamic amenorrhea, lost their period to undereating, is mistakenly told she has PCOS based on ultrasound or other mistaken ways of diagnosing, and then thinks, okay, I need to restrict more. This might be someone who's already restricting and thinking, oh, well, I've now read that, a low carb diet is the solution for PCOS. So now I'm going to go even more restrictive. And I've just seen that so many times. And that for that woman, if she keeps going in that direction, she'll never get a period back. Never.
When
So,
you say PCOS, is that endometriosis?
no,
What does
no,
that
it's a
mean?
different,
Sorry.
no, no. Yeah. So polycystic ovary syndrome is completely different
Okay.
from endometriosis. It's an endocrine hormonal condition where ovulation is not occurring regularly. There's
I
high
see.
levels of testosterone,
Mm.
um, insulin resistance often. Yeah,
So it sounds like to me your period is everything in the measurement of your hormones working right. Is that right? Am I reading
absolutely.
that right?
Well, and it's kind of a window into general health. So in my first book, Period Repair Manual, I called the monthly period, natural period, the monthly report card. So I can share with you. I mean, I've been seeing patients for decades, and I do see some men as well occasionally, or I used to see more. But when I'm with a man, like when I'm with a female patient, I'm like, okay, so tell me about your period. Is it coming natural? There's lots of things I can, if it's painful, if it's not coming, I can read between the lines and think, okay, well, that could mean this, or that could mean this, or that could mean gluten sensitivity, or that could mean, all different things. And with a man, I'm like, oh gosh, I don't have that barometer into your health at all. I just don't even have that information. I find it kind of hamstrung from not being able to. Yeah, there's no way to. Well, there's a few. I mean, for men, there's things like morning erections, which is actually kind of a good
Yeah.
marker of testosterone. There's a few things, but there's not the same kind of detail or nuance you can get from interpreting the menstrual cycle.
Never thought about a woman's period like that.
Yeah,
It's amazing. Changed
it
mine.
is.
Opened my eyes. I've got a
Yeah,
German Shepherd at the moment, and she's 7 months, and a guy who's right into hormones and things said, "Do not get her desexed because you'll wreck her cycle." And I'm actually hearing
interesting.
this, and I'm like, I'm not going to then. Yeah,
Yeah, well, yes, potentially. I mean, she could also benefit from her own hormones. Yeah.
I'm going to get these questions up. I had them actually ready
Okay.
to go, but Instagram has turned off on me, so I just had to
Okay.
open it again.
Give me the
So,
questions. Yeah.
yeah, absolutely. I just want to get onto these because a few women have followed me up and said, make sure you ask her these.
Okay.
So I'll just find it. It's in one of my stories here. 1 second, won't be long. Um, so how do you write these books in the middle of all your busyness?
Well, I have had to drop, like, I don't see as many patients as I used to, which is
Okay.
the main thing that had to go, which is sad because
Yeah.
I still see some because it's so good to sit down. I'm sure you can imagine because coach people or work with people. Like, there's nothing replaces that actual face to face, hearing people's stories, seeing what works. So yeah, I'm only doing that part time now. I can give a quick sort of just broad answer around good methods of avoiding pregnancy, especially for teenagers. So, well, first of all, I hope there's new methods coming because there's actually some new male methods coming that are not hormonal. They don't shut down testosterone because I don't have I have to sort of be equal to both sexes. I wouldn't want boys losing their testosterone or either. So there are some new male methods coming. There's one actually being clinically trialed in Melbourne. So Australians are always the ones to kind of get things done sometimes, I think. And so this would be it's a potentially like a temporary vasectomy that's just done in the doctor's rooms with a simple injection, and like it's once every 2 years, like something like that is going to be an absolute game changer. But in the meantime, for especially for teens, I'm a huge fan of condoms. I know young people, I've heard anecdotally that young people are just, well, I don't know, they're either not, I mean, no one loves condoms, but like sort of there's this sort of belief that they don't work, but they do work, especially if you get good quality ones that fit. So yes to condoms,
Yeah.
and also then yes to easy early access to the morning after pills. So in the unlikely event of a broken condom, which shouldn't happen but can, or a kind of condom mishap, then essentially the morning after pill, or plan B, or I forget what it's called in Australia, it available from the pharmacist. I don't think you need a doctor's appointment. it's um it's essentially just the pill, but
Okay.
you only take it, maybe never, or like maybe, once every 2 years or something. So through my lens, it's better because it's the same medication, but you're only dosing it once essentially to suppress ovulation, that cycle.
Awesome. Thank you. 10 minutes, 12 minutes of questions.
Okay, sorry.
Yeah,
Yes, keep
thank you.
going.
I
Yeah.
really value your time. Um, what's a must-go vitamin stack for a 40-year-old woman?
Oh, so the best supplements, is that what
Yeah.
you're?
Hmm.
Yeah. Um, right. Okay. Yeah. Well, I guess I'll just be quick. I mean, magnesium, 100%. I talk about magnesium in all my books. It helps the nervous system, helps insulin sensitivity. I usually pair that with an amino acid called taurine. There's a lot of data around that, around metabolic health and anti-aging. A lot of Australian magnesium products put those two together. So I learned that in Australia, actually, is that magnesium taurine combo is very powerful. I'll have to give a nod to creatine. It's um it's in my third book a little bit, but I mean, you've probably seen, like, it's good for mood, particularly in women. So it's not just for building muscle; it's actually good for brain health. This is during the perimenopause years. So this would be my top three. I've got some other ones, but yeah, and iron. Sorry, this is the other thing, because if women have do like no one should lose track of iron, because if women are losing a lot of blood every month, they're going to be iron deficient. And so then with menopause, and then for men, iron, you should not take iron supplements, because iron becomes actually basically toxic at some level. As you might know this, but we all, with age, especially for women after menopause, we start to accumulate iron, and that's not good.
And do you have a favorite brand, Lara?
Um, yeah, I mean, I tend to use, in Australia, if your listeners are there, like some of the practitioner only brands. So, I mean, some of them are available over the counter. So, I don't want to single out. I mean, there's lots of good
Yeah.
ones, but like
Yeah.
Orthoplex and Metagenics and Ethical Nutrients over the counter and Bioceuticals. And I'm trying not to leave
It's a
anyone
good
out.
quality one.
Yeah, I don't have I'm not aligned with any particular brand. Yeah.
Should women be using HRT in their mid-40s?
Well, uh, yes, I know we have 10 minutes. I mean, I will say, I'm a fan of hormone therapy for perimenopause, menopause in general.
You are?
I will just give a specific kind of push for, especially during the earlier phases of perimenopause when estrogen is already high. Progesterone, body identical natural progesterone, is actually one of the best treatments during those years. And that would be that's in Australia, that's available as Prometrium. So anyone who follows me in my last two books, I talk quite a lot, all books actually, I talk a lot about progesterone. But then eventually into, after the menopause transition, I think some, again, natural estrogen supplementation, like, can be helpful. There's a lot of controversy around this, as I'm sure you're aware. So, I mean, I do take a little bit of estrogen myself. I'm 55. What I said earlier about how menopause is normal and we evolved it, and that doesn't, in my mind, that doesn't mean we don't necessarily take hormones with it. So, but not everyone needs them. So that's the other way to put it.
When this lady stopped breastfeeding and she's had nausea times 1,000 and lightheaded and vomiting, is that a hormone thing? Is it what's going on there when she
I
stopped?
mean, without knowing the details of her case, I can't kind of speak specifically to her, but I will just point out that if there's a lot of nausea with hormones, that is usually from estrogen kicking in, or high estrogen stimulating a mast cell or histamine response. So this kind of, I don't know if people know the term mast cell, but those are the immune cells that make histamine. That's very much tied to estrogen. So every time estrogen kind of spikes or starts to go up, some women can experience those symptoms: headaches, nausea. Yeah.
Understand. Is too much fasting no good for women's hormones?
There's no blanket statement for that. There's no black and white answer. I would say, actually, women, gentle forms of intermittent fasting, like time restricted eating, overnight time restricted eating, has actually been studied a lot in women for the insulin resistance of PCOS and perimenopause. I think what happens, I think part of the problem, because I said earlier, women, if they undereat, they'll lose their period. And also women's nervous systems are more sensitive to fasting. So, and the other thing that's going on is you do have women with perhaps sort of disordered eating or like a real tendency already to restrictive eating. And what I've observed with my patients or heard from my patients is often it'll kind of transfer, like they might have been restricting in one way and realize that wasn't good. And then they kind of say, okay, well, now I can intermittent fast and are actually just still under eating. So
Yeah.
as long as a woman's getting enough calories and is feeling good and not the nervous system isn't stressed from it, then I think some type of intermittent fasting can be okay. So yeah, there's not one.
I
Yes,
was
sir.
just about to say, by the sounds of it, it sounds like you need to understand what your calorie maintenance intake would be and probably try and hover around that.
Yes. I mean, of course, that's affected by lots of different things. The other thing I'll just point out, I think it might be a good place to mention this, is because my third book's a lot about metabolic inflexibility and insulin resistance. So with metabolic dysfunction, insulin resistance, you have to have me back to talk about that. One of the main symptoms of that is being kind of locked into carb burning. So blocked out of the the default fat burning that should be most people's kind of default if they're in a fat, even if they're like 3 or 4 hours fasted and at rest, we should be mostly fat burning then. And because of insulin resistance and the common problem of metabolic inflexibility, a lot of people, both sexes, but a lot of people can't kind of dip into that fat burning the way they're supposed to. And then they're the ones, I hear this from those patients, they'll be like, I can't go through more than 3 hours without eating, or I start to feel faint or get low blood sugar. That's their experience. So the solution to that is to actually do all the things that improve insulin sensitivity so that you can start to go longer between meals and go overnight without eating and feel good. I mean, all the ways to build good metabolic flexibility, insulin sensitivity, is just like some obvious things like building muscle really helps, but addressing any gut problems, sheltering from ultra processed food. These are all things that I talk about in my third book.
I've got a number of things on insulin resistance. Do women
Yeah.
develop more insulin resistance or something, do they?
Well, women of reproductive age develop less.
Ah,
So estrogen protects us, shelters us from insulin resistance to some degree. I mean, young women can still get insulin resistance for sure, but with perimenopause and into the later phases of perimenopause into menopause, postmenopause, that all women will slide towards insulin resistance, depending on where they, what their metabolic health was like to start with going into that process. So I mean, I'm sure insulin resistance is epidemic. Like conservatively, it's estimated to affect 1 in 2 adults. And for older people, it's way more.
I don't know much
So
about it,
it's
but one
yeah,
lady said, does it affect weight loss? Like insulin
yes.
resistance is
Okay, well,
affect weight.
so the current paradigm, the old paradigm, has been that becoming overweight causes insulin resistance. But what I try to do in my latest book, and what I'll try to do here, is actually what the science flips that. I think what a lot of the research is showing, insulin resistance comes first from a variety of mechanisms, driving mechanisms, primarily the terrible modern food supply, which is everyone's exposed to, which is like we just grew up in, we're swimming in it, um, including probably vegetable oils, which is a controversial topic, but I'll just leave that there. Like insulin resistance comes first, potentially from a very early age for some people, and then that drives weight gain.
Right. So it's not just, it's like the whole leader, it's the whole everything you're doing.
Yeah. And insulin resistance, I mean, if people are wondering, well, wait, obviously we only got a few minutes left, so we can't go into all the detail, but I'll just give you a few easy things like high fasting triglycerides. If the doctors ever mention fatty liver, bingo, that's insulin resistance. That's what is happening there. That's what's
Right.
it's not named often in the doctor's rooms. Um, so
Is this all in your books?
yeah.
Okay, great. Two questions. Um, is it too late to start HRT in her 60s?
There's a bit, again, there's a lot of debate on that. I would think, again, it's about the type of HRT or hormone therapy. The modern lower dose, body identical natural hormone therapy is so much safer that I think in the right setting and with the right doctor and screening for all the risk factors, I think a woman could still start something in her 60s. But I would just say, just for caution everyone listening, at the moment, as in 2025, the pendulum is going to swing again, but we are in this like the narrative, some of the narratives out there are so like just promising that estrogen is going to fix everything. It's not that. I mean, like I said, I take a small amount of estrogen myself, so I know yes, sure, it can be helpful, but it's not the end all and be all. And certainly, tons of women have historically and prehistorically lived to a healthy old age without estrogen. So it's not a. I'm just trying to push back a little bit on this. The narrative that's out there, which is I think is incorrect. Yeah.
And last question, Lara. This lady really wants me to ask you, can she fall pregnant naturally in her 40s?
It's genetics. A lot of it's
Yeah.
genetics. So I think most women know, basically. There's outliers who can. So I think it's just about. I mean, there's a quite a range, like a 10-year range of kind of the end of fertility. For some women, it's a lot younger in their late 30s. For some women, it's going to be older. And it's also, I mean, it depends on genetics fundamentally. It depends on the male partner and his situation, because male fertility declines with age as well. It depends on immune system and just there's many different factors. So
And
yeah.
what's on the horizon for you? As we're wrapping up right now, what's on the horizon for you? Like you seem to be woman on a mission.
Yeah.
Yeah.
Well, yeah, I am doing a bit more writing. I'm working on another book, which I won't share what it is just yet. But yeah, I do, of all the hats that I wear. I don't know if you're the same, Matt, but like I wear lots of different hats, interviews, presentations, clinician. My favorite is writing. So I think that's what I'm best at. So I just need to get into that, get back to
Well,
that.
I'm going to
Yeah.
read your book, and I'm not even a woman.
Yeah.
I'm going to read your book because it's very,
Yeah.
and I hope everybody, there's so many questions here, we can't even get to them all, but
I know.
and Lara, I really appreciate your time today, and we'll support you every way we can.
Thanks so much, Matt. Great to meet you.
Thank you. See ya.